This episode of Doc Talk is brought to you by First Bank. We're not just your neighborhood bank, we're your neighbors. Our local team lives up to the name, putting our customers and community first. To experience First Bank difference, stop by any of our 13 Knoxville area locations or visit firstbankonline.com. First Bank, member FDIC.
Hello, my name is Dr. Rob Page, and thank you for joining us for another episode of Doc Talks. Doc Talks is a podcast that is produced by the Knoxville Academy of Medicine and uses its constituent physician members to provide information to patients about topics that are of interest to them, be they common topics or be they uncommon, or be they something that has to do with the current situation. And I feel so fortunate to have with me today Dr. Michael Antiporta. Dr. Antiporta is a general surgeon with Premier Surgical, and he is here today to talk to me about foregut surgery. Now, first question I got to ask, what is foregut surgery?
I'm so glad you asked. Just simply, foregut surgery refers to surgery of the esophagus and stomach.
And so basically, when you're talking about foregut surgery, you're talking about anything that would involve basically this part and nothing below, generally, the diaphragm or the lower intestines.
Right.
Okay. So what kind of surgeries would I be looking for, or as a patient, if I have a symptom, what kind of disease actually involves this part of the anatomy?
So, there's a wide variety, and the term foregut surgery is, I would say, not common parlance. It's it's almost like it's a subspecialty of general surgery, which doesn't have its own certification. But the terms come more in vogue as with the increasing subspecialization in medicine, to have surgeons, specialists who focus on specific areas of the anatomy. So we have hepatobiliary surgeons, we have colorectal surgeons. We even have hernia surgeons, but foregut surgeons are the ones who really dedicate their thoughts, education, training to really care for those patients who have like swallowing disorders and benign and malignant conditions of the upper GI tract.
So, and this is an area in which you specialize.
Correct.
Okay, excellent. So, under what circumstances would I need to come visit you as a patient? Let's say that I have. So basically anything, let's say I have problems with swallowing, let's say I have problems with reflux, God forbid, let's say I've been diagnosed with cancer. Are these different types of surgery that you perform?
Yes. So those are all the realm of a foregut surgeon. And foregut surgeons are trained to take care of those disorders with open or endoscopic or surgical means, laparoscopic, robotic means. But for me, what defines a foregut surgeon is not just being able to do the operations, but to have a really in-depth understanding of the physiology and knowing when medication might do better for a patient or if something endoscopic should be done. But it's treating patients who have reflux, treating patients who have esophageal motility disorders such as achalasia, patients who have delayed gastric emptying, which is gastroparesis, patients who have paraesophageal hernias or hiatal hernias, and patients with esophageal cancer, gastric cancer, Barrett esophagus. And these are all complex conditions that actually require a lot of complex testing to really understand what's going on so that you can get the best outcome for the patient.
Now, you mentioned a variety of diseases there, and I'd like to sort of hit a few of them, one at a time. You mentioned achalasia, difficulty swallowing. Let's say that I'm a patient and I've been diagnosed with this by my gastroenterologist, what sort of surgical options or what sort of treatment options would be available to me if I went to come see you?
Sure. So there's a very rare disorder that sometimes comes to light in a patient who usually the most common symptom is dysphagia. But interestingly, the symptoms can even
dysphagia is
trouble swallowing.
Okay, gotcha.
Solids or liquids. But some of the symptoms can masquerade as reflux, even because so essentially the primary disorder with achalasia is non-relaxation of the lower esophageal sphincter combined with either aperistalsis of the esophagus or spasms or panesophageal pressurization. And I throw those terms out there not to just try to make myself look fancy, but again, to illustrate that these are conditions that are best left to surgeons who have decades of experience, like some of the other surgeons in Premier, or somebody like me who's had like a year of dedicated fellowship training to treat those disorders. So the testing for achalasia is pretty in-depth. It involves endoscopy and biopsies to ensure that there's not a cancer that's hiding and causing the narrowing at the point where the esophagus meets the stomach. Manometry testing, which is a test of how well the esophagus squeezes and also how the lower esophageal sphincter is functioning, which again would be non-relaxation of the lower esophageal sphincter. Doing X-ray tests to also characterize the appearance of the esophagus, because that correlates with the function of the esophagus. And once you have those tests in place, you can sit down with your surgeon and decide, should I have an endoscopic procedure, or should I have a laparoscopic operation? The ways to treat this disorder, which is a disorder of the enteric nervous system of the esophagus and the lower esophageal sphincter, all aims to ablate or essentially cut the muscle fibers of the lower esophageal sphincter so that it'll open and allow a patient to swallow more normally. The training I've received, I've learned to do these laparoscopically. It's called a Heller myotomy, where we make 5 keyhole incisions on the upper abdomen.
So just 5 little tiny incisions.
Mm-hmm. Yeah. Similar to like how gallbladder surgery is
Gotcha.
done. But so laparoscopically, we free up the esophagus and stomach. If there's a hernia there, we fix that at the same time. But we surgically divide the muscle of the lower esophageal sphincter. And then because that causes reflux afterward, then we combine that with a partial fundoplication. Usually in my hands, it's a toupee, which is coming behind, but there's other ways to do the fundoplication. The other ways to treat this are endoscopically. You can dilate these, and there have been some good studies showing that for certain subtypes, it can be as effective as a Heller myotomy. There's pneumatic balloon dilatation. There's Botox, but that's not a durable solution because Botox wears off as a plastic surgeon.
As we know.
And then one of the newer ways, well, I say newer, but it's been done for the last decade. The surgeons who trained me in my fellowship were some of the pioneers for this procedure in the United States. But this is the POEM procedure, which is a per-oral endoscopic myotomy. And this is a technique where the endoscopist makes a small cut from the inside on the lining of the esophagus and then travels through the layers to endoscopically cut the muscles from the inside. So the advantage of that is you don't have the incisions on your abdomen. The recovery can be faster because you don't have those to worry about. The only trade-off is that there's a slightly higher risk of having bad reflux afterwards. So I don't think it's for every patient, but in select patients, the POEM procedure may be better than a Heller myotomy.
So intrinsically, what we would anticipate would be somewhat of a simple problem, just difficulty swallowing. There's a huge variety of different treatments and different options that are available to us. Yeah. So it is important that we go see someone who does have specialty training in that area, so we can make sure that we pair the correct procedure with what is exactly our problem, and any other problems we have as a patient.
Correct.
So we talk about difficulty swallowing. One of the other things I'd like to mention is the next topic we'll go on with, and again, I think that's a motility issue, is gastroparesis. Now tell us what gastroparesis is.
So another relatively rare condition, very challenging to treat, but gastroparesis is delayed emptying of the stomach. And there are 3 main causes. The most common cause is related to diabetes, since diabetes attacks the microvasculature. So it causes vision issues, obviously arterial vascular issues, and then it can affect function of the stomach. There's idiopathic, where we don't know the underlying cause, and then there's medication-induced, which can be related to if you're on opioids chronically, that can have a negative effect on your stomach function, and some neurologic medications. So the challenge with gastroparesis is because there are medications that help with emptying the stomach, but they can have side effects. For instance, something called Reglan is used for gastroparesis, but that can have some neurologic side effects. The treatment for gastroparesis, when it comes down to surgery, typically the options are to do a laparoscopic pyloroplasty, which divides there's a theme here, dividing muscles, but it divides a muscle in the stomach, and after making the opening, closing it in a way that leaves the stomach valve open, so the stomach can empty more easily. There's another treatment called gastric neurostimulator, which is a device that's implanted under the skin, and then 2 leads are sutured to the stomach to help give some regulation to the enteric nervous system of the stomach.
So essentially, it stimulates the nerves to make the stomach move.
Essentially,
Yeah.
And then a third way that this can be treated is almost similar to the POEM procedure, but there's a way to get an endoscope without incisions on the abdomen to tunnel through the layers of the stomach and then to selectively divide the muscles of the pylorus, which is what's divided by a pyloroplasty. And again, sorry for all the jargon, but it's an endoscopic way to divide the muscles and improve gastric emptying.
So again, what we would say, well, I'm having trouble with, stomach motility. My stomach isn't moving correctly. But again, a variety of different treatments that if we come see someone like you, you would be able to say, well, you won't necessarily need surgery. You could possibly use medications. Or in some cases, surgery would be good for you. And it can be very minimally invasive. It's not something that, so if I were to get, you mentioned the POEMs or the endoscopic procedures, recovery time on that, is it fairly long or?
That's where that procedure shines because for those patients, they usually stay in the hospital overnight so that we can do a swallow study to make sure there's everything's emptying as it should. But since you have no incisions, you go back to work the next. If you want to, you can go back to work the next day, or go back to doing whatever you want. And then the diet progression is a fairly rapid progression from clear liquids to full liquids to blender-ice to soft. But I think the recovery is the fastest after a POEM procedure.
Most excellent. So when we talked about motility issues, you mentioned also hernias. Now tell us about the type of hernia. We have another episode where we've talked about different types of hernias, but this is another type of hernia.
Okay. So you're referring to the paraesophageal hernia. So hiatal hernias are defects in the diaphragm. You have 3 openings in the diaphragm for your esophagus and aorta and vena cava to go through. When the opening around the esophagus is too big and the stomach can slide up and down, you can have a hiatal hernia. If it's too big, then part of the stomach can slide up alongside the esophagus and cause problems with swallowing, cause reflux symptoms. And what we most worry about is volvulus or twisting of the stomach on itself, causing intense pain and possibly endangering the stomach. So those are paraesophageal hernias are a pathology that's fixed laparoscopically. Generally, they're always fixable laparoscopically. It's very rare these days to have to make an open incision like on your abdomen or on the side, like in the old days. Generally, if you have an experienced foregut surgeon, he's somebody who will be able to do it all laparoscopically.
So again, something that can cause a lot of problems, but can be fixed fairly easily, again, with minimal downtime, minimal time in the hospital, and minimal time before you can actually get back to your regular activity.
Yeah, minimal time, definitely, compared to like the old days, how they used to do it. But I mean, that's an operation that usually the patients who usually have these are my favorite patients, older women who might have some like scoliosis and like years of losing vertebral height, so that tends to splay the diaphragm and contributes to these hernias getting bigger. But that operation, even if it's done laparoscopically, will knock you down for probably a couple weeks to a month before you start feeling back to normal.
Gotcha.
So,
but you'll still be able to move around, and perhaps you may not feel your best, but you still would be able to do fairly routine activity after a minimally invasive procedure like that.
Within a few days.
So we've talked about motility, we've talked about hernias. One of the other parts of your surgery is you treat certain types of cancers and certain types of precancers.
Right.
Can you tell us what those are?
Sure. So the precancer you're talking about is Barrett esophagus, and then the cancers are esophageal and gastric. So as far as Barrett esophagus is concerned, this is a premalignant condition of the lower esophagus, usually associated with years of chronic reflux. It increases the patient's risk of progressing to cancer. So when patients are diagnosed with Barrett esophagus, it's always a mandate that they have to get control of the reflux, whether it be with medicine, which can be appropriate, or surgery if the medication is not doing the job. And not only that, but they need surveillance to have endoscopy every couple of years to make sure it doesn't progress to something more sinister.
So when you mention surveillance, what would surveillance entail?
It depends on how progressed the Barrett esophagus is, but at the least it's an upper endoscopy every 3 years.
And let's say I have Barrett's and it doesn't go away or doesn't seem to get better, or God forbid it would progress into cancer. Would this be something you would be able to treat? And what different types of treatments would be available for that?
Sure. So this is again where there are different procedural approaches such as endoscopic. So these lesions can be ablated with radioactive RFA, radio frequency ablation. They can be resected endoscopically. We call that endoscopic mucosal resection. And then in some cases, and then if it's progressed to cancer, then we have to start thinking about if somebody needs an esophagectomy.
Esophagectomy. And similar type treatments those would be available for gastric cancers, or maybe even like a gastric ulcer. You would have similar type treatments, or
so for esophageal and gastric cancer, there's actually a fair amount of differences with regard to the treatment. For instance, with esophageal cancer, these patients who present with more locally advanced disease often will offer neoadjuvant or primarily chemotherapy and radiation first, and then reassess how they've responded and then offer surgery after that. For gastric cancer, usually it's just chemotherapy. The regimens are different also, and then the operations are different because for gastric cancer, usually it's just going in the abdomen. For esophageal cancer, sometimes it's just the abdomen and the neck incision to reconnect things, because we use the stomach, we tubularize the stomach and use it to replace the esophagus. Sometimes you need incisions on your side. We call that a 3-field approach, where we have to operate in the abdomen, on the side, and also the neck. But yeah, for esophageal cancer and gastric cancer, there are differences. And this is where a multidisciplinary approach comes into play, with contributions from like a gastroenterologist who's doing the advanced endoscopy, surgeon, medical oncologist, and radiation oncologist, all coming together to treat these less common cancers, but that are still lethal.
But at the very least, we've learned today. First of all, I've learned today what the foregut is, what it's considered, and the importance of being, if we have a problem in an area, going to see a surgeon or someone who's trained in that area of specialty, because they have a lot more options available to them about how it can be treated. Excellent. Now, you're with Premier Surgical. Would you like to give us some additional information about your group? Maybe if a patient has been diagnosed with any of the issues that we've talked about and would like to schedule an appointment with you or see you in follow-up?
Sure. So my office is, I'm with Premier Surgical Associates at Fort Sanders Regional Medical Center. My office is on the campus at the Center for Advanced Medicine. I think the easiest way to get in contact with me or arrange to see me is through our website, premiersurgical.com, and you can find our office number on there. And we see patients very quickly, and that would be the easiest way.
Most excellent. Well, thank you so much for joining me here today, Dr. Antipota, and thank you for sharing all this information with us about foregut surgery. And with that concludes this episode of Doc Talks. Doc Talks is a podcast that's produced by the Knoxville Academy of Medicine for patients, and basically provides information from its member physicians to give patients more information about how they can address issues or problems that are important to them. Thank you so very much for joining us. I'm Dr. Rob Page, and you guys have a great day.
This episode of Doc Talk is brought to you by First Bank. We're not just your neighborhood bank, we're your neighbors. Our local team lives up to the name, putting our customers and community first. To experience First Bank difference, stop by any of our 13 Knoxville area locations or visit firstbankonline.com. First Bank, member FDIC.